So what made you become a doctor, Dr. Bessette?
I was fascinated with, first of all, the science involved. And I had also been exposed to a number of physicians that I wished to emulate. And as time went on, not only the science fascinated me, but the opportunity to do something very positive in people's lives. That was a genuine interest.
So where did you attend medical school?
Georgetown University in Washington, D.C. Graduated in June of 1965. Graduated in June of 1965 from Georgetown Medical School.
Would you like to talk any further about the medical school or your residency or internship before we move on to your practice?
Medical school was really just the beginning of an educational process that continues. It's just the foundation and the base on which to build. And it provided me with what I feel are the tools and the background to continue being in school for a professional existence. And the same applies to training years. They are for training, but also the basis for continuing to improve one's skills.
So how do you find yourself keeping up with changes in education now and, right after you graduated and finished your training? How did you keep up then?
At the time, it has always been very difficult to keep pace with everything. Initially, it was really journals. However, there's been such an explosion in new developments in medical knowledge in so many fields that it's very difficult to keep up. And one tries to go to as many conferences as possible, professional meetings, and try to follow through publications as best you can. And then when particular topics come up, try to delve into them in greater depth and hope you retain that information for the future. The access via the internet and electronic means has made it easier to get information. It's you don't have to make trips to the library and that nature. But it's, despite these aids, it is still a difficult task, okay, to stay current, and you do the best you can.
So the journals, the internet, and the conferences help,
right.
And so, so what did you choose as your specialty in medical school?
I did not choose a specialty in medical school.
No, in training.
In training, I chose to go into infectious diseases. The infectious diseases appeared to me to be a specialty that well, maybe I'm sort of a little of a detective. It's a certain amount of detective work that was needed in diagnosing. I was fascinated with infectious disease processes. I was challenged by the fact that you don't have many chances. You have to make some decisions, and you hopefully are correct, because you don't have many opportunities to second guess. Also, many of the illnesses are very dramatic illnesses that require very prompt intervention. That fascinated me. Also, the ability to, at that time, do something positive. Many of the things that we deal with are reversible, and that also was a very appealing process. So there were many things that culminated in an interest in infectious disease. And again, also, there were individuals that practiced in the community that served as role models that you wanted to emulate, you wished to emulate.
Do you remember how much it cost for you to go to medical school?
Yes. My medical school costs were approximately $36,000 to $40,000 for the total cost.
So were you influenced at all by the cost of medical school in terms of how you first practiced? Did it
I
affect
don't-
your choices in any way?
Of going to medical school?
No, of how you became a doctor after you graduated.
No, that did not affect it. Okay. Now, the cost of the medical school did not affect what I was going to do subsequently. Is that what you meant?
Yeah, that's what I
No,
meant.
it didn't.
How do you feel that the cost of medical school today affect the choices of young doctors?
And the choice of their careers?
Right.
I think many of the physicians who graduate from medical school today are faced with overwhelming debt, okay?
Right.
My total indebtedness for medical school was $16,000. That is minute and minuscule compared to some of the debts that students today have. In 1965, that was a lot of money. That was a huge sum of money. But proportionally, it's much greater for these graduates. And I personally feel that many of them are driven into specialty areas that provide much higher reimbursement rates in order to help defray these costs and pay off the loans. I think that influence is much greater than it was 30, 35 years ago. That influence today is much greater. They are attracted to some of these higher reimbursement specialties because of these overwhelming debts.
So what year did you start practicing here in Worcester?
The summer of 1972.
Okay. Could you describe a typical day of practice when you first started?
Consisted of making rounds in the hospital, seeing patients that were on my service, seeing patients whom I had been asked to see by other physicians, going to the office, seeing some patients there, and then going back to 1, 2, and sometimes 3 hospitals to see patients again.
Which hospitals were you at most of the time?
At the time, spent a fair amount of time, most of the time, at the old St. Vincent's, Hanneman Hospital, the old Hanneman Hospital, and Memorial Hospital, and occasionally would go to Fairlawn and to what was the old Holden Hospital in Holden.
Were you going to say something?
No.
So what were the hours like on a typical day?
They were long days, starting at 7 in the morning and sometimes ending at 9:30 at night, and that is no different.
Have you ever made any kind of house call during the course of your career?
I have made house calls early in the practice for under certain circumstances, patients whom I've known for a long period of time, and if I knew that they were unable to get out. But those are few and far between. They are rare. They were rare, and they would continue to be rare. In many ways, I just did not feel comfortable that I could provide what most patients needed in that setting.
How else have you communicated with patients outside of your office, aside from house calls?
Communicate by phone, try to speak with them about their laboratory data, about their concerns, and then see them in the hospital. I have not embraced the concept of filling out a form that has different laboratory studies on it and marking off a check mark and sending it in the mail stating that these are normal or these are abnormal. I have maintained over the years a practice of asking patients to call me in 2 days, 3 days, for the purpose of reviewing their laboratory studies. Then I call them back. That gives them the opportunity to be a part of this. It makes them somewhat responsible also for some of their care. And it provides like a sort of a double check that we have communicated. It's quite possible I could put something aside and say I'm going to call and forget to call, but if there's serves like a double check. And it gives me the opportunity to discuss any abnormalities, which you cannot do in a very impersonal form letter that said this is abnormal. And I can use the opportunity to discuss any variations in the labs from before, discuss the significance, which you can't do on a plain piece of paper, and also an opportunity to ask other questions and discuss other issues that are probably not related to the laboratory data, but just simple questions about how the trip visiting the grandchildren were the previous weekend goes far in cementing physician-patient relationships.
Do you feel like physician-patient relationships have deteriorated at all over the past 50 years?
I think overall they have. And some of it is physicians themselves have a different attitude about what their role is in regard to patients. Some of it has been driven by the employers or the insurance agents to perform and maintain a certain productivity level. In some respects, patients are forced to see certain physicians. They have had a relationship over the years with a certain physician. Then their insurance changes. They are now forced to see someone else. and that does not forge a very good physician-patient relationship. So there are many factors that I think have played a role in the fact that the relationship between a physician and a patient has changed over the years. I think some of the physicians have a much different attitude regarding what their role is in relation to patients than previous physicians did. But I think a large part of it is due to the environment in which physicians are now practicing.
Right. Well, would you like to back up and talk a little more about your rounds in the hospital, or have you finished in that area? Your hospital rounds?
Hospital rounds consist of visiting the patients, reviewing the chart, trying to obtain lab data, x-ray reports on which to make decisions about further therapy or changes in course of management, or decide to discharge the patient. The rounds have changed dramatically. The rapid availability of laboratory results is not as good as it had been in the past, okay? Obtaining some information regarding patients' conditions that are not listed in the chart is not as easy because there aren't as many nurses who know what's going on with the patient. That aspect has changed dramatically. Nurses are forced to maintain huge sheets of data that are probably worthless as far as we're concerned, and they do not have time to put down and monitor and document probably some of the more important information. And if it's there, it's just more difficult to find. So it's the performance of hospital rounds is not as pleasurable as it previously was. Okay. I don't know if is that what you were looking for?
No, that's, I would think that the availability of lab data would be better now, but the reverse, I guess.
Very difficult. Yeah.
So who are your patients in general? I mean, like what type of people were they, and where did they come from? I've been very fortunate in that the patients I've been privileged to care for over the years have come and continue to come from a cross-section of the Worcester community. Initially, most of them were from Worcester. As time has gone on, we have had patients referred from either by other patients or by physicians from some of the outlying towns, and even from northern Connecticut. But is that what you're looking for? Yeah.
Yeah, okay. Now, patients come from a variety of sources. They come by word of mouth, by friends or relatives, or by other physicians. Over the years, my practice has changed in that I do not have as many primary care patients as I previously did. But most of those patients came by word of mouth from other patients. Now my patients are referred by other physicians, and some of them are forced to come here because their insurance dictates that they come here. So that's the difference.
Okay. What do you think it was like for your family to have a physician in the household, especially one who worked such long days as you did?
It was very difficult. Fortunately, I believe they understood what we were doing, and whenever we did get time, we made the most of it. But they were very understanding of my needs, what I felt were the needs of my practice. And we tried to make up as best we could when we did have the free time on weekends and vacations.
What were the most typical illnesses that you dealt with early in your career in the 70s, I suppose?
Early on, the most common problems we dealt with were probably respiratory infections, skin infections, wound infections, okay? Diarrheal illnesses, opinions regarding reasons for and the sources of fever and how to manage them, and for choice of antibiotics. Those have remained probably the mainstay of our practice over the years. There have been new diseases that have occurred since we started practicing. New illnesses, but basically the nature of the practice is the same. What is the problem? How do you best handle it? How do you prevent it in the future?
What are some of the new problems that have arisen during the course of your career?
Okay. When I first went into practice, Legionnaire's disease was not in existence. That is an illness that occurred since I started practicing. A certain type of antibiotic-associated diarrhea called C. difficile enterocolitis has emerged. Okay. The emergence of an infectious cause for peptic ulcer disease and gastritis, H. pylori infection, is new. Of course, the most dramatic has been the epidemic of AIDS. Those are the major things that we see. We had some penicillin-resistant bacteria. Now we have a variety of organisms resistant to a variety of antibiotics.
During the course of your practice, what have you seen as one of the most important breakthroughs in disease treatment?
Probably some of the technological advances in the lab and in support services such as X-ray that can help us establish a diagnosis. Okay. CAT scanning and MRIs have enabled us to image areas and see things that we previously could not see. Okay? And there have been major advances in the laboratory that have speeded up, so to speak, the recovery of organisms and testing them.
And how about in disease prevention? What breakthroughs have you seen there?
Probably the biggest breakthroughs have been with vaccines. In my career, smallpox has been eliminated. Polio is almost non-existent. We've eliminated measles, mumps, and rubella. or essentially eliminated them. There are breakthroughs in the management of things like meningococcal disease, meningitis, pneumonia, and influenza.
What was the worst epidemic that you can recall, if there was any?
I can't think of anything. There have been some very interesting outbreaks of disease, okay? I can recall a picnic, a company picnic one summer a number of years ago, a local company, and most of the people at the picnic became ill with shigellosis. But that was a short-lived problem that, a very interesting phenomenon that occurred in my training, but prior to my entering practice, was the outbreak of hepatitis in a Holy Cross football team. And I was privileged to be involved in the workup and the investigation of that process. But those things come to mind as sort of outbreaks or epidemics.
Could you briefly describe how attitudes towards smoking and cancer have changed throughout the course of your career?
Dramatically, but not enough. Smoking was commonplace among physicians and among the general public, and thankfully the public perception has changed. Efforts have been made to educate young people about the risks of smoking, and fortunately we have seen, I believe, a significant decrease in the number of people who become addicted to tobacco. There are still a significant number of individuals who, despite public education and all sorts of educational materials and efforts, continue to smoke. But overall, I think there is an awareness, a much more public awareness of the dangers of smoking, and it is not condoned as it was before.
Has your personal attitude changed at all over the years, or has it always been the same?
I have always considered smoking to be a nasty habit. It hasn't changed, okay? My feelings have not mellowed about it at all.
What is something that doctors seem to take for granted now in terms of technology that you didn't have at some point in your career? Would you say it's all those radiological?
Yes, I would think that the advances in the diagnostic abilities and the treatment abilities in radiology we take for granted, okay, that was not available. And I'll give you an example. I can recall early on, as part of the evaluation of someone with unexplained fever, individuals have so-called fever of undetermined origin. You would go through a workup involving a number of laboratory tests, and if you could not find an answer after a period of time, sometimes 2 to 3 weeks, part of the workup would be to have a surgeon open the abdomen, explore the abdomen, looking for something, even taking out a spleen as part of the workup. I haven't seen that done now in many years as a result of the fact that we can image the area with CAT scans and we can tell if there are some enlarged nodes or an enlarged spleen. So that's an example of something that, okay? I mean, you speak to young physicians today and they'll be looking through a chart, an old chart, or you'll come upon a patient and they'll want to know why the spleen was taken out. You tell them it was part of a fever workup. They think that was barbaric and they have no idea, but that was the state of the art at the time. And they find this very strange.
What technology is still in frequent use today that you used early in your career in medical school?
Some of the culturing techniques, the stain, cultures of body fluids is the same. Blood counts, checking for, the amount of whites, blood counts. Some of the chemistry determinations are the same. That hasn't changed much.
Did you have access to the new technology in your field right away?
Yes. Mm-hmm. Yes.
Is there anything that you would like to see invented in medicine? Doesn't have to be technology.
Excuse me. Yes, I would like to see an effective treatment for HIV disease and a vaccine for the disease. I think, and also effective treatment for hepatitis C and possibly a vaccine. Those illnesses will ravage mankind, not only our population, but worldwide population for years to come. Okay. The toll that they are going to take cannot be predicted.
How have you seen the progress in those areas come along? I mean, do you think that the vaccines are close to being made?
It may be some time yet, but it will happen. Mm-hmm.
What were some of the most important drugs in your practice early on, and how have they changed over the years?
Some of the more important drugs were some of the penicillins, some of the cephalosporins, and sulfur preparations. A very important drug early on in my career was a drug called chloramphenicol. We hardly ever use it anymore. Some young physicians have never seen it used. Some have never even heard of it. But it previously was a very important agent. And over the years, the penicillins and the cephalosporins have been manipulated to the point where they have a different spectrum of activity, a broader spectrum of activity, and a half-life has been altered so that you can now give drugs once a day, twice a day, and previously drugs had to be given 4 or 6 times a day. And there have been newer agents also with less potential toxicity and side effects, such as the quinolones, some of the new cephalosporins. And some of these other agents have gone by the board. We have, we don't use some of them anymore.
Did you always have access to the drugs that you wanted to use?
Yes.
Have there been any other breakthroughs in drugs that you've seen that you haven't already mentioned?
Yes, well, the availability of agents to treat viral illnesses. It's only been recently that we've been able to effectively treat the herpes viruses, herpes simplex, herpes zoster, or shingles, with a drug called acyclovir, with acyclovir and its cousins. And now there are agents available to treat other viral illnesses, such as hepatitis C. And there are drugs available to treat the HIV virus. So the advent of antiviral agents is new. They were not in existence in the 1960s, 70s. Okay.
How have changes in the drug industry affected your practice?
Just the progress that has been made has made my ability to practice easier, that's all. Yeah, very much so, yeah.
How did patients without money receive health care early in your career?
They were seen without any problem, okay? Patients were admitted to a hospital, and the hospital had a designated area that patients receive care from in. If it wasn't a designated geographical area, the patients were assigned to one of the doctors. All the doctors took turns in being the responsible physician for that patient, for the patient. Most of the care was, everyday care was administered by the house staff, okay, interns and residents, and they were directly supervised by one of the attending physicians. And in some ways, the care that these patients received was probably better than the care that other patients received.
So do you think that everyone who needed health care received it at the time?
Yes, they did.
Over the years, have you seen Worcester compared to other places in terms of providing care for the underserved?
I think Worcester has done its job in that respect, has fulfilled its responsibility. I think most of the physicians in Worcester have also fulfilled the responsibility. The fact that, you know, the various government agencies have mandated, have made available to individuals insurance, okay, and then mandate that patients be seen, but have made, and at times they make it very difficult and put many restrictions on the physician. They want you to see the patients, but you are very restricted about what you can do. You've got to check with this person, that person, and then at times the reimbursement rate has been very low for some of these patients. And that has discouraged many physicians from being willing to take on the care of some of these patients, because it's so difficult. It was easier previously. It was easier to do under a previous system than it is now with the bureaucratic stipulations that are placed on you. We all see patients who are underserved.
What were some fears and concerns about socialized medicine that you may have seen many years ago? I don't know if this is past or before your time.
Some of the fears about socialized medicine?
Yeah, fears and concerns.
The fears about socialized medicine are that it will interfere with individual physicians' freedoms, okay? It will provide a an atmosphere that will not be very positive between physicians and patients. There will be there'll be a lot of regulations, and it just makes it make it very difficult to practice medicine with all sorts of forms and regulations and details that are probably not necessary. You can still, if the majority of physicians are conscientious and do things honestly and appropriately without having to have all sorts of checks, balances, and forms and agents of that nature. The socialized medicine would eliminate competition. It's not consistent with the American economic system of free trade and competition. And it has been a dismal failure in other countries where it has been tried. It essentially comes down to a rationing of health care. And the individuals who tout socialized medicine, the politicians, some business people, fail to point out that in countries where a socialized system exists, it's a dismal failure. And all you need to do is go north of the border in this country and see what a socialized system has brought. And in some of these countries, there has arisen a separate insurance system that patients pay into that rivals the public health systems of the countries. So it's just too big to manage effectively, and it's fraught with too many pitfalls.
Did you see many physicians get involved politically on the topic of socialized medicine?
No, and that's probably one of the major problems, one of the major reasons we have the problems we have today. Physicians have not been politically involved.
What were your feelings on Medicare and Medicaid when they came into being?
They initially looked like they were proposed as a way of taking care of patients who were otherwise underserved, and I think initially that was fine. I mean, but they have become major bureaucratic agencies that cannot keep up with what is needed in a way of reimbursement for the technology that's involved in the advances that have come up in medicine. And they're just not the answer to the issues that we face today.
Overall, how have you seen the government's involvement in healthcare affect the public's access to care?
Despite the fact that the government states that this helps everyone get medical care. It makes it more complicated to get care by making all sorts of requirements about what can be done, when it can be done, getting permission for somebody to do this and that. It just makes it more inefficient. And it has not answered the demands for care.
What would you like to see happen with the government and healthcare?
I would like to see a more realistic appraisal on the part of politicians that if they really want the American public to have the caliber of care that we now have, that we've become accustomed to, then they are going to have to explain to them that they cannot have it for the same costs that the other countries to which they're comparing us have. That if you're going to have access to mammograms, CAT scans, MRIs, PET scanners in order to rapidly diagnose something, have access to the latest treatment modalities, you cannot put restrictions and lowball the providers with extremely low reimbursement rates and treat healthcare providers, whether it be physicians, nurses, or lab techs, as public utilities. They have to be treated as professionals, and they have to restore some sort of confidence in the healthcare professions, in addition to providing the appropriate funding for the healthcare professionals to provide what the public deserves and wants according to what the politicians are preaching. I don't know if that answers your question.
No, definitely. Well, I'm going to move on from access to healthcare now. And, well, could you tell me how doctors' salaries have changed throughout the course of your practice?
They have risen, okay, sometimes consistent with the remainder of the economy, but probably not as rapidly or to the same rate as other professions. And a lot of that has been due to the reimbursement policies of these agencies that have taken over the care of the patients. The salaries are not consistent with other professions, considering the nature of healthcare professionals. I think healthcare is probably the most precious commodity that the American public has. And to entrust your care to a professional, they should be appropriately rewarded. And I don't mean that we should become extremely wealthy, but I believe that physicians' services, their knowledge base, their training, years of training, is much greater and longer than other professionals. And the service they provide is just as important, if probably not more important, than some of the other professionals in this world.
Doctors need to be paid more than baseball players, right?
All right. doctors should be paid more than baseball players. Well, baseball players probably shouldn't be paid as much as they're paid, okay? All right. No, I don't think any physician needs to be paid $20 million a year, okay? On the other hand, I don't think any baseball player is worth $20 million a year.
So where was most of your income from in the early part of your career?
From the insurance carriers, yes, and some fee-for-service patients paid directly, but a lot of the income was from insurers, the old indemnity fee-for-service type of income, as opposed to presently a large part of our salary is, and a lot of physicians are capitated by various insurances, okay? They have, for a fixed amount, they are taking care of the patients.
How much was the office visit when you first started practicing?
Oh my gosh. $12, $15 probably. I don't know. I don't recall.
How has malpractice changed? Malpractice insurance changed over the years, as well as its impact on your practice?
Well, first of all, the rates for liability insurance have soared, okay? But one thing that has changed is that the carriers have adopted a different philosophy. Early on, they had a philosophy that, well, we'll see how much it's going to cost us to settle this, and we may just pay it off, okay? Now, they have adopted in recent years a stance that, well, if this is defensible, we're going to defend it. And so the number of payouts is probably less in the long run. But it costs a lot of money to defend a lot of these things also. But, I mean, that's one thing has changed. The philosophy about how to handle this has changed. But the awards have also increased dramatically. Probably absurdly so. Okay.
How did you learn the business of medicine?
With difficulty. We never received any training or courses in medical economics or running an office. I started with another physician. I shared his office space, and I learned. I was in training, okay? Essentially was by making mistakes and not knowing how to do billing and stuff like that. And so you learned a little bit about it as time went on, but there was really no formal training.
So do you think that medical economics is a topic that should be covered in med or sometime in the future?
Yes, definitely. Definitely be more emphasis on how physicians can survive in this world.
What changes have you seen in the demographics of the Worcester community?
There's been a marked increase in the number of minorities. Okay. It was very unusual early on to have to employ the services of a translator to see patients. there were a few people of Polish extraction that probably required an interpreter. But at the present time, we have a very large diversity of ethnic groups, and they're young people. So that's changed dramatically, okay? Is that what you were looking for?
Yeah.
Okay. We probably have also seen more of the problem, of the illnesses that are the result of social conditions, drug use, prostitution, alcohol abuse. We see the diseases that are caused as a result of this, and so we're probably more aware of some of this than we previously were. And also the HIV epidemic has brought out to the forefront a group of individuals that previously society did not recognize, and namely the gay population. Okay? So these individuals were there, but we weren't as aware of them as we are now. I don't know if that explains it. Yeah.
Of course, yeah. How has women's health in Worcester changed over the course of your practice?
There have been a number of initiatives by the various organizations in town to promote women's health. Not only, the ordinary, the pap smears, but, a concentrated effort to do screening, mammograms, bone densities, educational programs about hormone replacement, osteoporosis. These were virtually non-existent in the 1970s. So there have been great strides in this.
Have you seen any changes in children's health that you would care to comment on?
I'm not really involved. I'm sure they have been, but I really can't comment on them, right?
How do you feel the role of the physician in this community has changed over the years?
The role of the physician probably has not changed, but the circumstances under which the physician delivers has changed. Okay? The doctor still sees patients, listens to patients, prescribes medication, orders studies, evaluates this. Some physicians operate, perform surgery, but the milieu, the atmosphere in which the physicians are performing this, and the methods by which the physician is recognized for this has changed dramatically. But it's still the same thing. It's still a relationship between a doctor and a patient.
Right. What are some things that you like and don't like about practicing here in Worcester?
I like the people. I like the individuals with whom I practice. I have the highest respect for the patients and my colleagues, and I think they have provided me with patience. They have provided me with they've demonstrated a confidence in me, and that makes one feel great. So I think the atmosphere that I practice in and that I've been able to thrive in has been one of the most positive things that one can experience. What don't I like about practicing in Worcester?
Yeah. If there is anything you don't like.
I can't think of any
Okay.
really negative things.
Is there a favorite or any fond memory that you would like to take a minute to share right now before we wrap up this interview?
There are many fond memories. Okay, I can't really
Sure.
come up with one in particular.
Right. Well, lastly, what advice do you have for younger doctors, Dr. Bessette?
Listen to the patient. If the answer is, and be patient with not only the person you're dealing with, but understand that disease is an evolving process. And if the answer isn't there today, it may be tomorrow, and may be there next week. But primarily, listen to the patient. And eventually that patient will tell you what's wrong. The patient may not come up with the scientific medical terminology, but sooner or later the patient will tell you what's wrong with them.
Well, that brings us to the end of our interview today. Thank you very much, Dr. Bessette.
Okay, you're welcome.